Ajenthen, before I present you to the attendees, can you please explain in brief what you will talk about today?
Yeah, so today I want to talk about a new potential treatment measurement for glucose control in persons with type 1 diabetes. And it's a publication that we just published in September 2020 in Diabetes Care. And I'm happy to share those data with you.
Thank you. Now I will just shortly present today's speaker before the talk starts. Ajenthen Ranjan is a medical doctor from University of Copenhagen, and he did his PhD fellowship at Hvidovre Hospital. Currently, he's in a 2-year postdoc position at Steno Diabetes Center Copenhagen. His main interest is in technology and type 1 diabetes, and he's currently in collaboration with Technical University of Denmark developing an artificial pancreas for persons living with type 1 diabetes. And he has published more than 30 articles in peer-reviewed journals in the last 5 years. That was all from me. And Ajenthen, I will now make you presenter, and you should be able to share your PowerPoint. I hope you will all enjoy the webinar.
So it should be shared right now, I think.
Yes.
Yes.
Yes. Now it is as you want it.
Okay. Thank you. Thank you, Hannah, for those nice words and introduction of me. And as I just briefly mentioned, this talk webinar will mainly focus on the effects of time in range as a glucose marker for persons with type 1 diabetes. The study was published in Diabetes Care, and the title of the manuscript is called "Improved Time in Range is associated with reduced albuminuria in individuals with sensor-augmented insulin pump-treated type 1 diabetes," and more fancily called Puma Tiger study. Before I dig into the publication, I'll just briefly allow to come with an introduction of type 1 diabetes and glucose control. We know that persons with type 1 diabetes need insulin, and can either get it administered in therapy or insulin pump therapy. Regardless of the delivery, persons with type 1 diabetes still have a risk of chronic diabetes complications, such as retinopathy, neuropathy, cardiovascular disease, and what we will talk about today, nephropathy. We know that after the diabetes complication control trial, that diabetes complication can be reduced with an intensive insulin therapy. The intensive insulin therapy involves more than 3 injections and a near normalization of glucose levels during the day. And by that, you can reduce and prevent the onset of diabetes complication and its progression. The same trial also established this nice relationship of HbA1c level and the risk of diabetes complication. It shows that the relative risk on the y-axis and the A1C on the x-axis, that the higher A1C you have, the higher risk of diabetes complications. Ever since, HbA1c level has been the gold standard for glucose control, and hemoglobin A1c is a measure for how glycated hemoglobin is in blood cells. Higher A1C means higher glycation of the hemoglobins. But the hemoglobin A1c is a retrospective measure measuring the average of glucose exposure for the last 2 to 3 months. And it's therefore a surrogate marker for glucose control. There are several factors that may affect the A1C level as shown listed on the left side. And these are mainly affecting factors that affect the red blood cell turnover, the glycation process, and the assays. Another limitation of the A1C is that it cannot explain anything about hypoglycemia, hyperglycemia, the glucose profile during a day. Luckily, there are glucose sensors. Glucose sensors measure glucose values every 5 minutes, and it's a device that is attached either to the arm or to the abdomen or wherever. What it measures is the interstitial glucose concentration, which is a measure that reflects the blood glucose level. And there is a physiological lag time between the glucose concentration in blood and in the interstitial tissue, and that is dependent on the diffusion rate. With this continuous glucose monitor, we are able to see both highs and lows and how much the glucose varies and the fluctuations. But one key interest and measurement that has been drawn from these CGM measurements are the time in ranges. The time in range is a measure for how much time a participant or a patient user has a glucose level between 3.9 and 10. This is called the time in range and also shown as the green bar. Time above range is the yellow bar shown as time, the concentration above 10, and time below range is the concentration between 3.90. There are recommendations available now on what is recommended for persons with type 1 diabetes. A person with type 1 diabetes is recommended to have at least 70% of their time in range, which is equal to 17 hours. Less than 25% above range and less than 4% below range, respectively 6 hours and 1 hour. But how good is time in range to measure glucose control? This study and several other studies has shown this nice relationship between time in range on the x-axis and A1C on the y-axis. And you can see there is a nice linear relationship between those two measurements. But as you also can see, there are some outliers, and as I mentioned before, these may be due to alterations in the red blood cell or in the hemoglobin's glycation. Another thing that you should be aware of is the time range of 70, which approximates an A1C of between 6.6 and 7. But the main strength with HbA1c is its prediction of diabetes complication. There are only a few studies that have shown the link between time in range and diabetes complication. If we take, for instance, the diabetes complication control trial that I mentioned before, here participants were measuring finger prick measurements 7 times a day. And based on that and post hoc analysis, they saw that the time in range of these finger prick shown on the x-axis and the frequency of retinopathy and microalbuminuria at panel A and panel B, that you can see that there's a clear relationship between the time range and the frequency of these diabetes complications. However, this study was, as I mentioned, based on finger prick measurements, and other studies that are available are either retrospective observational data performed on type 2 diabetes participants, or if CGM data was available, these data covered less than 14 days. And the recommendation today is to have CGM data around 14 days. So we need some studies that prospectively shows that the change in time in range affects the risk of chronic diabetes complication in persons with type 1 diabetes. So we seek to answer that question. We looked for a study that somehow showed some diabetes complication, but also after introduction of glucose sensors. And here at Steno Diabetes Center, we were lucky that Signe Rosenlund and colleagues in 2012 to 2014 performed this study that investigated the effect of sensor-augmented insulin pump therapy versus multiple daily injections on albuminuria. And this was a 1-year randomized open-label parallel group study. And what they did was they looked at urine, blood pressure, blood samples, and luckily also had glucose sensors. The study design was an open-label randomized parallel group study. Participants were included if they were adults with type 1 diabetes, were insulin pump pen therapy, had history of albuminuria, HbA1c more than 58 millimolar per mole, stable RAS inhibition therapy, and had an estimated GFR above 45. They were allocated either to a sensor-augmented insulin pump therapy or to multiple daily injections, and were followed for 12 months. During this period, every 3 months, blood samples, urine samples, blood pressure, and glucose sensor values were obtained. However, for the multiple daily injection, sensor values were only obtained at baseline and at study end. Here's the flow chart. 84 participants were screened, 16 were eligible for the study and randomized 1-to-1 to SAP therapy and MDI, and 26 out of 13 in the SAP group completed the study, and 29 out of 30 in the MDI group completed the study, giving a total of 55 participants in the study. The baseline characteristics are, as you can see here, the age was 50 years old, diabetes duration of around 30 years, predominantly males, HbA1c level was 75, urinary albumin creatinine ratio, which is a marker for albuminuria and the diabetes nephropathy, was around 19 to 100. And except for the plasma creatinine that was significantly higher in the sensor augmented pump, both groups were comparable. Here are the data, the results. On the y-axis, you have the HbA1c level, and the x-axis, you have the months from baseline. You see that there is a significant change from baseline to study end, within and between the groups, with a significant improvement in the SAP group. When we look at the primary endpoint of that study, the change in urinary albumin creatinine ratio, there was a separation between MDI group and the SAP group. However, this did not reach statistical significance. However, when adjusting for the HbA1c level, this difference was significantly different. The conclusion of this article was then that SAP treatment reduced the albumin creatinine ratio, reduced HbA1c level, and that the effect of on diabetes nephropathy was independent of HbA1c level, and that there must be some other factors that could explain the benefits of that treatment. And we then considered in this publication, maybe CGM could be the explanation. So the hypothesis of the study that we published was that the changes in CGM-derived time and range affect the risk of nephropathy in persons with type 1 diabetes. The aim was to compare the changes in albuminuria over a year with the changes in CGM-derived time and range in persons with type 1 diabetes. The study design was the same, but be aware that the CGM availability was only from baseline to months for the sensor-augmented insulin pump therapy. For the MDI group, we did not have sensor values throughout the study period, only at baseline and at study end, and these were only 5 days per session. We therefore, before doing the analysis, did not include the MDI group. So here are the results from baseline to 12 months. You can see that CGM downloads were 26 at baseline and 22 at end, and that the time and range was significantly improved within the group with 13%. These improvements were also seen for time above range, time below range, for mean sensor glucose values, and for glucose variability measured as standard deviation, coefficient of variation, and at last, the glucose management indicator, GMI, was also significantly improved. And GMI is formally known as the estimated HbA1c level. But what we were more interested in was its relationship to albuminuria. Here you have a visual schematic description of the results. On the y-axis, you have the time and range, and the x-axis, you have visits. The yellow is time above, the green time in, and the red time below range. And you can appreciate that the time in range increases during this trial period, and the time above and time below range decreases. When looking at the corresponding HbA1c level and the urinary albumin creatinine ratio, we see there is a significant reduction in these, and that this was significantly explained by the time and range. So what we saw was that urinary albumin creatinine ratio decreased with 19% per 10% increase in time and range. So this is the first study that prospectively shows that a reduction in CGM-derived time and range reduces the albuminuria in persons with type 1 diabetes. We also looked at other associations than time and range. We saw that mean sensor glucose values, the GMI of the sensor glucose, and the mean arterial pressure was significantly associated with changes in urinary albumin creatinine ratio. Also have to mention that on the other hand, that the glucose variability did not have any effect on the change in urinary albumin creatinine ratio. I'm not hiding any data from you, so I'll also show you the when including the multiple daily injection. So here, be aware that the data, the CGM data for the multiple daily injection is only 5 days, and we recommend to have at least 14 days CGM data in order to get a valid time and range estimate. But when we include those, the significant does not, the association did not reach significance, at least in the unadjusted model. When adjusted for the HbA1c level, we get a p-value that is near significance of 0.052. The conclusion of the study is that changes in time in range was significantly associated with albuminuria in persons with type 1 diabetes treated with SAP. Improvement of sensor augmented pump therapy on albuminuria is independent of HbA1c level, but may be explained by improvements in a time range, mean sensor glucose, and GMI. Time range complements HbA1c level with real-time evaluation of the glucose control in persons with type 1 diabetes. At last, I want to say thank you for my collaborators in this study. And I also want to thank DDA for allowing me to present this research in a different forum than usual. Thank you.
Well, thank you for accepting to speak at our webinar. And now we have time for questions or comments. You can write your questions in the chat, and if you prefer to ask your question verbally, then just write your name and then I will unmute you. I know from previous webinars that sometimes it takes a while for the attendees to write questions.
Yeah.
So we'll just wait and see.
Yeah. Should I stop sharing actually?
You can do that. Yes, you can do that.
Okay.
And while we're waiting for questions, I will just open a small poll, and I hope everybody will take time to fill in the poll. Thank you. I can see somebody already did that. Thank you. Thank you for filling in the poll. Really appreciate that.
I must have been really, really clear with my presentation.
Probably yes. Thank you. Filling in the poll. We really appreciate that. And remember, you can ask your questions, or if you have a comment, you can write it in the chat or ask to be unmuted by writing your name, or you can use the raise hand function in the participant panel if you prefer. Now there's a question. I can only see it's just a short while, and I will make it visible to you.
Okay. So Anna Korska Berg asks, when do you expect time in range to replace HbA1c in the daily clinic? As I also stated in the last slide, I do not think that that time in range is mature enough yet to replace HbA1c level. There are many literature on HbA1c level, and it's linked to diabetes complications that makes it really difficult to remove. And I will also say, not everyone is ready to have a sensor. It requires to have a sensor on. So HbA1c level is there to be there. Like, I don't think it will be replaced by this. Sensors will, time range will only be an addition to HbA1c level for now, at least.
Thank you for the question, and thank you for answering it.